My name is Megan Poe, and I'm joined today by my colleagues Patrick Katsianis and Tyson Traveler. We are here today to tell you about member care coordination, the way to an efficient Central Valley submarket. Our agenda today will begin with a brief overview, followed by a listing of our challenges. Then we will go into our strategy, operations, and the financial impact, and we will conclude with a brief review. For lending us a few moments of your time today, we promise to demonstrate to you how member care coordination, which will be referred to as MCC from here forward, will save you $54.4 million and over the next 5 years, increase membership revenue by $181 million as a consequence of ensuring high-value care. Our goal through MCC is to create an efficient Central Valley submarket that improves access and reduces overall costs and expenditures. Kaiser Permanente is the largest integrated nonprofit delivery care system in the United States. You guarantee your members high-quality care services that improve their health and the communities that you serve. By being both the provider and the payer, you have been able to develop a unique care delivery system that places emphasis on improving the health of your members. In addition, you have a very sophisticated electronic health system. KP Health Connect has the ability to update in real time, which adds value for your members as well as your providers. Kaiser Permanente Fresno Medical Center, or KPFMC, is a 168 licensed bed nonprofit foundation hospital of Kaiser Permanente. It is responsible for a 157-mile stretch from Atwater to Wasco, covering over 250,000 member lives. The Visalia Medical Office Building, or MOB, is located 45 miles south of KPFMC. It serves as a community-based outpatient clinic, providing primary and urgent care services to the members of the Central Valley region. The region is made up of the cities Visalia, Tulare, and Exeter. From the data provided by KPFMC, we have been able to develop challenges for your Central Valley region. First, primary care providers cannot accommodate the volume of patient visits. In 2013, there were 122,000 member visits to the Visalia MOB, but we know that this number only makes up for 51% of total Central Valley member visits. Each provider in the MOB is seeing around 4,305 visits, so we know that your patients are seeking their care elsewhere. Members are leaving the network and seeking care at non-Kaiser Permanente facilities. 2013 data also states that there were 10,551 treat and release visits for Central Valley members. 71% of those visits went to a non-Kaiser Permanente facility, representing $9.5 million in claim costs. This leads us to conclude that your members are not receiving appropriate care in the Central Valley region since they are not able to be seen at the Visalia MOB. I would like to introduce you to Rosa. Rosa is a 70-year-old woman with type 2 diabetes. She has been unable to relocate her provider to the Visalia MOB and continues to travel 90 miles round trip anytime she needs to be seen. One day, Rosa awakes experiencing extreme dizziness, so she calls the Visalia MOB for an appointment since they are the closest in-network provider. She is told that there is no available appointments for the next 2 weeks. Her condition worsens, and when her right arm feels numb, she presents at the Tulare Regional Medical Center, ED. She is admitted for symptoms of a stroke. Eventually, she is discharged to Kenyon Regional Skilled Nursing Facility, where she spends her time there with no follow-up from her primary care provider, who had no knowledge that she was even admitted. This member further illustrates the disconnect in the care continuum. The challenges presented by your Central Valley members have led us to develop several options for the direction of our strategy. Those proposed alternatives are recruit specialists, build a freestanding ED, negotiate contracts with existing hospitals in the Central Valley region, or member care coordination across the continuum. MCC is a three-pronged approach that includes increasing access to care teams, implementing and executing care guidelines, and providing a post-acute care alternative. Using the factor analysis, we ranked each alternative on a scale of 1 to 10, with 1 being the lowest and 10 being the highest, against factors such as cost savings, capital required, timeliness, probability of success, decreased non-KP utilization, increased access, and your ability to control the strategy. We summed the weights of each alternative, and MCC across the continuum had the highest weight. It is our recommendation that MCC will provide the best solution for you and your members. I will now pass it off to Patra, who will discuss our strategy and operations.
Thank you, Megan. I would now like to go into more detail on our proposed strategy and our operational goals. To begin, the NCQA has created elements for becoming a patient-centered medical home. These include providing care that is team-based, comprehensive, and preventative, as well as allowing for patient empowerment, IT integration, and population health management. We believe that we can fulfill these elements through our MCC across the continuum strategy, which Megan just defined as a three-pronged approach that will increase access to care teams, implement and execute care guidelines, and provide a post-acute care alternative. We believe that through this strategy, we can reduce ED utilization, particularly at our non-Kaiser Permanente facilities, resulting in a cost savings and a more mission-aligned strategy that allows us to improve our members' health. In increasing access to care teams, we recommend you recruit 11 new care provider teams. These teams will include primary care physicians, advanced practitioners, such as nurse practitioners and physician assistants, and a care coordination nurse. Through these teams, members in the Central Valley will be able to more readily access their care teams. Our care coordination nurses will monitor our over 65 and our chronically ill members to ensure that they are interacting with our providers in the right place and at the right time. In addition, these nurses will be following up with members who are seen outside of the network to ensure greater services through enhanced MCC. In continuing to increase access, we recommend you build a multi-service outpatient center, or an MSOC, in the next 3 to 5 years to supplement the current Visalia MOB. This is in order to increase continuity of services available in the Central Valley, to address the region's operating room shortage, and to increase availability and convenience for our members. The MSOC will include additional primary care offices, specialty clinics, and an ambulatory surgery center. We envision the MSOC to be the place where where the grandma can go for cataract surgery, where dad can follow up with a cardiologist, and where junior can see the pediatrician. They're offering a large spectrum of services all in one convenient location. Our second objective, to implement and execute care guidelines, will be done through creating evidence-based care guidelines that will allow for the identification of treatment for care for members regardless of where they present for their care. The Institute of Medicine has defined care guidelines as systematically reliable statements that allow both the provider and the member access to information that will guide their decisions for various circumstances. Other regions of Kaiser Permanente have already begun to create national care guideline summaries through their guideline development teams. So we believe that our providers in the Central Valley will be able to easily collaborate, bringing in Fresno specialists with Central Valley primary care physicians to figure out how to best utilize and expand upon these tools in order to improve members' care. The last prong, providing a post-acute care alternative through bringing healthcare home. We suggest you create a Kaiser Permanente home health agency. This is to increase member satisfaction, decrease hospital readmissions, and also to increase effectiveness of communication between providers, home health, and post-acute care setting providers and the members and their caregivers. This will also provide an alternative to skilled nursing facilities for members in the Central Valley. As you can see through our implementation schedule, our proposed strategy includes both short-term and mid-term goals, focusing first on increasing access to teams and implementing care guidelines through integrated IT. This will build a strong foundation before building the MSOC and expanding Central Valley services in 2019. Now, in order to successfully increase access to care teams, our operational goals include building an MOB in the Tulare region and including an on-site imaging center. This is going to house the 11 new care provider teams, allowing 33 new providers to provide access to care in the Central Valley region. The imaging center will provide a more comprehensive visit for your members, as Fresno radiologists will be able to use teleradiology capabilities through IT integration to diagnose members. In addition, recruiting care teams will be done in conjunction with Permanente Medical Group's existing recruitment dinners and career fairs that occur in Fresno, as well as reaching out to the local family medicine residency program in Visalia and the local nursing programs at Cal State Fresno and Cal State Bakersfield. In order to successfully implement and execute care guidelines, our operational goals suggest that you recruit 5 physician champions. They will be used to promote the use of care guidelines through IT integration through the clinical decision support tools available in KP Health Connect. These 5 physician champions will be spread between the Visalia and the Tulare MOBs and will serve in a leadership role to educate our providers on how to best access the care guidelines based on a member's diagnosis, thereby empowering our members based on giving them greater information about their condition, as well as allowing providers to practice at the top of their license, therefore leading to a reduction in specialist referrals and the need for our members to travel to Fresno for their care. And lastly, in order to successfully provide a post-acute care alternative through bringing healthcare home, we suggest you initially recruit 10 home health nurses and equip them with tablets that will give them access to KP Health Connect. This will allow for greater communication so providers are able to follow the care that is happening to their patients when they're discharged home. In addition, through IT integration, providers who are currently monitoring members who are in skilled nursing facilities will be able to recognize when it is medically acceptable to discharge these patients home a little bit earlier, allowing for a reduction in the average length of stay for our members in skilled nursing facilities, and giving our members the comfort of knowing that when they are discharged home, they will do so with the support of a home health care team. I would now like to pass it to Tyson, who will go over the financial impact of our proposed strategy.
All right, thanks, Patra. So first off, our strategy will hinge on 3 different avenues for cost savings. First, in non-Kaiser Permanente facility visits, a reduction there. Second, in a reduction of total hospitalization of our current Kaiser Permanente members at KPFMC. And finally, in a reduction of expenses at skilled nursing facilities due to our home health program. We believe that this will accumulate to a total of $54.4 million in savings net present value. You can see a quick breakout here that breaks that up into the 3 avenues, as well as the 5 years of savings that will accumulate. And it gradually increases as we implement these strategies based on our timeline. First, a reduction in non-Kaiser Permanente treat and release expenses. We believe that critical to our plan is building the medical office building in Tulare. There's a large number of members in Tulare that are seeking care outside of the network. It makes sense that that's a good area to build this building. As we do it, we'll increase access to care for the members in that area, thereby also freeing up access to more care at the Visalia Medical Office building. Access to care is a big part of decreasing these expenses. Second, we also believe this access to care will provide members with better health. They'll be able to more regularly see their primary care physician and won't feel like they can't get in or need to wait until they present in an ED with more acute conditions. We believe that this will increase year by year to 40%, which is our goal. We set a goal of 40% because we could easily hit that goal with the amount of providers that we're providing in the Visalia MOB with the 11 care teams over the 5 years, that we could capture that volume. Total savings, we believe, over 5 years of $23 million. Second, a reduction of the total hospitalization expense for Kaiser Permanente members. Once again, as the last strategy, due to access, we believe that by increasing access with the Tulare Medical Office building, as well as that would improve access to Visalia as well, that our members would have the access that they need to this primary care. As they get this access, we believe that as they see their providers more regularly, they will achieve better health. And critical to it also is our MCC component, the member care coordination, that as we implement the care guidelines, there will be much more continuity in the care they're given and a seamless transition from the primary care to the specialist. Both of these will add to the increase of the health of our members. And as we do that, we set a modest goal in year 1 of a 1% reduction of total hospitalization. Now, we know that it is a goal for Kaiser to improve the health of its members, and that an effect of improved health is decreased hospitalization. We set a cap at 5 years, just having it incrementally grow by 1% in reduction. And we did cap it at 5 because we understand that there will always be a need for the hospital, that there are some conditions that are appropriate to be treated at the hospital and patients will need to be admitted there. Now, we believe this will have a total cost savings of $19.5 million accumulated over the 5 years. And finally, our home health program and the SNF cost savings. As we know, this last year, about $12.5 million was spent on skilled nursing facilities outside of the Kaiser Permanente network. We believe that there are 3 ways in which our strategy helps reduce the cost. First, as you can see, the total hospitalization reduction. This is a small savings, but we believe that 1% of total reduction of hospitalization due to better member health from the previous slide will lead to a downstream effect of a 1% decrease in patients who would have been admitted that will now be discharged or not hospitalized at all and not needing home or SNF needs. Second, discharge from the hospital to a home health setting. Currently, Kaiser Permanente in the Central Valley is discharging 27.8% of its members, age 65 plus, to a skilled nursing facility. The national average is that 28% of patients go anywhere other than home when being discharged, and also found that 13% go to a skilled nursing facility. So we do know that we're discharging quite a bit more than the average to the skilled nursing facility, and we believe that our home health strategy will give us another alternative to discharge patients in a more cost-effective way when it's appropriate for their medical care. We believe that if we can decrease the discharge percentage from 28% to 20%, that we can achieve a savings of $3.4 million over the first year. And lastly, we believe that by discharging patients early from the skilled nursing facility to home health, once again, those who are declared medically appropriate by a physician, that they can end their stay at a skilled nursing facility and finish their rehabilitation at home, where it's more convenient and more comfortable for them. We believe that if we reduce the average bed days from 11.6 to where it currently is to 10, a small reduction, that we could see a savings of $1.2 million. That totals for $4.8 million and projected over a 5-year savings of about $25.5 million. I want to touch briefly on the cost for the MSOC that Patra mentioned. The MSOC is a strategy that we purposely put in the 3 to 5 year area. We believe that it's critical that we first achieve the access needs to primary care in the area, and that by doing that, we can achieve the savings of $54.4 million as we've outlined. And as we do that, we believe that we have positioned ourselves to be able to expand even further in the Visalia area through an MSOC. We know that it's going to require upfront capital. For the 50,000 square foot facility that we looked into, we calculated that at about $38.5 million. We also know that through Kaiser Permanente's model, this isn't a revenue generator. What this is, however, is convenience for our members in the area. It provides them with better access. It provides more reason for patients to choose Kaiser Permanente in the Central Valley, as this MSOC will have the capabilities to house specialists and give the Central Valley the ability to recruit specialists to the area in the future for the first time. And that by doing that, we believe that we can improve the health of our members and improve the convenience. So we know that this strategy is contingent upon further growth of membership. And we believe that through the convenience that it adds, it will allow us to double the growth rate which is projected. The projected growth rate is 2.7%. We believe that membership growth can achieve around 5%, with a net effect of about $37 million on years 2 through 5 post-implementation, and a net present value of $31 million, showing the viability of the project. And finally, as the last slide touched upon, the way that we're going to increase revenue through Kaiser Permanente is largely through membership dues and through the membership that we achieve. We know that the only way that we're going to get the membership and the growth that we desire is by providing the highest quality care and by providing the access for our members so that they know that they can rely on Kaiser Permanente in their area to fulfill all of their healthcare needs.
Following up with Rosa, we will find that through MCC, she is now able to access a provider in Tulare, not having to travel more than 20 miles from her home round trip. She will be an active participant in her care, so that if she wakes experiencing dizziness, she can call a provider nearer to her, and her provider can follow the care guidelines in place for her treatment, and she will be flagged as a risk if necessary. MCC provides the best solution for you and your members. Not only does it save you $54.4 million, but it increases access, reduces hospitalizations, and reduces non-KP visits. MCC is mission aligned and can ensure that your members will have their health care improved and that you can improve the communities that you serve. This concludes our presentation, and we would like to open the floor to questions.
For your 11 primary care teams, are you utilizing the current underutilized physicians, or are you bringing in an entirely new group of doctors?
You can go ahead and pull up the slide if you want. Our plan is to bring in new physicians beginning to recruit year 1. Patrick's going to pull it up right here. We have our care team breakdown here of what it, consists of the physician, the advanced practitioners and such. In the first year of the care team, about $1.8 million. That's recruiting 3 care teams to that area, and then providing 2 additional care teams for the rest of the years. So it was our assumption, based on the information given, that we did not have underutilized physicians in that area, based on the 4,300 visits per provider, compared with the Fresno area's 4,100 per provider.
And then you say you're going to build a new facility when the current facility is not being utilized efficiently. So why would you invest in a new facility before you try to improve the current facility?
The investment of the new facility, as we mentioned, will be in 2019. We put it quite a ways down the road, specifically so that we could stabilize, I guess, the current environment, that we could, build the small medical office building out in Tulare first. Once we've done that, we believe that will open up access, because we believe that it is underutilized, but the physicians who are there are being used at their capacity. So we believe that there's not that, the availability for patients.
Also, through care coordination, we find that since the urgent care is part of the underutilization, that the lower acuity patients, members, can be routed through the urgent care so that the higher acuity can be seen by the primary care physicians, and that that will help them to practice at the top of their license.
So just as a quick follow-up, if that MOB is not going to come online until 2019, all of the costs associated with that construction is in 2015.
It's the MSOC that's not coming on until 2019.
The MOB will be built in year 1. And then
In Tulare?
In Tulare, yes. The Tulare MOB will be built. I mean, it'll take a year, but by the end of 2015, I believe.
So can you talk a little bit about, you did a good job, I think, of talking about your strategy around access, right? So just recap for us, right, what you've done from geographical access and how you've addressed the primary and the specialty care needs. Just give us a recap, and then I have a question. I just want to make sure I'm asking it right.
Pull up the map of the new locations. So when we add the new location here in Tulare, we know that 17% of our market resides in that area, so we're hoping to keep them from going to the ED. We're seeing a lot of treat and release going to the ED at Tulare Regional Medical Center. So we're hoping to capture those patients and provide them access in this region.
Okay, so where is your effort to increase the specialty care? Because that was one of your stated objectives, right? So where are the specialists at? Are they at this MOB exclusively, or do they go to the other?
The access for the specialist will be through collaboration, creating the evidence-based care guidelines. The primary care providers will coordinate or collaborate with the Fresno specialist in the beginning of the plan, but then further down the road, when we build the MSOC in 2019, that's where we hope to bring in specialists, because currently we don't have anywhere for the specialists to operate. If we bring in a general surgeon to the area, there's no hospital for them, and we can't promise that they will see the volume that they need to sustain a practice.
But for 5 years, you're not going to address the specialty gap?
We're addressing it through our care guidelines, giving the primary care physicians the ability to practice at a higher level through this information that the specialists have provided for them, freeing up space for the specialists to see the truly acute needs of our members in Fresno. They'll still be traveling to Fresno for that care, but our specialists will be able to see a greater, or our primary care physicians will be able to see a greater acuity through the care guidelines.
Thank you.
Yeah.
Talk a little bit about the patients themselves. So we're building buildings and facilities, we're offering new services. What's the communication, the marketing strategy for ensuring that we get our patients back, basically?
The marketing strategy will be building these buildings. Obviously, as you said, there needs to be more strategy than just that. We do hope that the members will realize there's care in the area. We reached out to the Tulare County officials office and asked them about their employees, what their health plan options were, what they chose and why. They mentioned that of their over 3,000 employees, only about 200 employees chose Kaiser Permanente's health plan. They gave them that option, as well as Blue Cross, and they said a majority chose that. We asked them why they thought that was, and they said that the main reason is because the only members that were choosing Kaiser Permanente were those who lived closer to Fresno. They said that they didn't have the access in their area to make it to make sense to choose the provider. According to her and her assumptions, if there was access and convenience in the area, she believed that more members would choose it. But currently, the ones who actually live in Tulare choose Blue Cross Blue Shield and see people elsewhere. So majority of their members were living in between Visalia and Fresno.
So how do you address the immediate need for access to specialty care prior to an MOB coming online or anything of that sort? I mean, those patients are looking for care and treatment today. They can't wait for you to break ground and to build a new building.
And that's why the care guidelines will take effect immediately. We felt that was a strategy that could be implemented quickly, as they already use some care guidelines. And we are going to address the needs of chest pain will be one that we'll address with our care guidelines. Looking at the community needs assessment, we'll address diabetes as another one. And some of the more critical, I guess, conditions for that area, and implement those care guidelines first. Care guidelines are something that can be implemented a lot more quickly, I guess, than, like you said, building a building. And if we implement those and those go as we project, based on the research we've done, they will free up specialists to see those with more acute conditions.
So we found examples of existing care guidelines for Kaiser Permanente in other areas, and we think that's a good place for our physicians to start. And then they can move from there, addressing the needs identified in the community needs assessment. The obesity, asthma, and the chest pain is one of the treat and release visits that we see as a top diagnosis.
Can you talk then just a little bit about, so right now you we have the challenge of our population going to non-Kaiser providers. So you're going to have a little bit of additional market resource, but not really kind of the specialty piece. And so I understand that you're going to have our providers work at the top of their license and do everything that they can. Just remind me, is there any additional, though, resources that you're suggesting we're going to network with from a specialty perspective? That's the first part, right? Second one is when we do have our specialty resources, how are we going to bring those patients back into the system if the relationships are already established in the community?
Let me make sure I'm understanding. The relationships that our members from Central Valley will have are going to be with specialists in Fresno?
Right, but ultimately, you're saying that geographically, you're going to bring resources closer to where they reside, right? We're assuming they're chronically ill, so they're going to need these relationships perhaps for the remainder of their life. So I have a specialist in Fresno. Are you moving that specialist to the new site in 2019? Or are you going to have created community relationships and you're going to ask those specialists to stay engaged in the network?
I think we're going to be recruiting additional specialists to bring into the MSOC, but bring them as part of the Kaiser Permanente model where there's open communication between providers, there's the integrated IT, there's the real-time KP Health Connect, so that patient information is easily transferable to a new specialist and the relationship can easily be transferred. And hopefully, because of the convenience, the patient will not have a problem with being seen at a specialist in Central Valley and not having to travel anymore to Fresno. The relationship won't be broken, however, with Kaiser Permanente because they'll still be in network and there's just still going to be open communication between providers.
And during our field research, we found that in other areas, it's common for specialists to come down once a week or maybe twice a week or rotate with a group to come and see patients. So we think that that's a great way to keep with the connections that we have in Fresno.
Probably only got 20 seconds. You got a non-compliant population now with the guidelines and the new locations of care coordination. It is your belief that you can get folks to behave the way you want Kaiser patients to behave?
Yeah, we absolutely do. We got into a marketing strategy initiative, and we thought that one thing, it clearly shows that the members are going elsewhere and they're choosing to go elsewhere, regardless of the higher cost to do so. To me, it sounds like an education issue that we talked about.
Thank you.
Thank you.
Good job.